It's a late fall day at the Athenaeum in Pasadena, California. We're looking at the Einstein balcony, where Einstein used to enjoy looking at Caltech during his visits to the campus. Hello, this lecture is about Parkinson's disease, mostly about therapeutic approaches that reduce the symptoms of Parkinson's disease. In a final lecture, we'll then talk about stopping the degeneration of Parkinson's disease. First, as warned, when we discuss psychiatric diseases, we'll talk a bit about advantages in carrying just one gene for the disease as opposed to two. That's the so-called heterozygote advantage. There is none known for Parkinson's disease. Indeed, as you remember, some Parkinson's mutations are dominant. One copy of the diseased gene is enough to cause the disease. So we'll talk about symptomatic relief, and of course the major agent for symptomatic relief has been in use for about 4 decades. It's L-DOPA. And here is its structure. It is a zwitterion, not neutral by itself, but has a balanced positive and negative charge. It penetrates into the brain via a transporter. Dopamine itself does not penetrate into the brain. Once in the brain, L-DOPA, it is a substrate for an enzyme called a decarboxylase. And the carboxyl group is removed by that enzyme, and we have dopamine. Now, in order to get maximal effectiveness and minimal side effects in the peripheral nervous system, L-DOPA is usually mixed with carbidopa, which inhibits decarboxylases. It does not cross the blood-brain barrier, and it therefore prevents hydrolysis in the blood and in the peripheral nervous system, and so we don't get peripheral effects of dopamine. In addition, Parkinson's patients also take D2 receptor agonists, such as bromocriptine. This seems to reduce the dyskinesias, which I'm going to talk about on the next slide. L-DOPA, of course, remains effective only as long as sufficient dopaminergic neurons remain to take up the dopamine through their dopamine transporter, to concentrate it, and then to liberate it into the extracellular space where it can act on receptors. So when a patient loses too many dopaminergic neurons, despite the fact that the dopaminergic neurons sprout as well as they can, ultimately L-DOPA becomes ineffective. In addition, there are side effects of prolonged use of L-DOPA. There are dyskinesias, so-called bad movements, literally, which are very common in people who've used L-DOPA for many years, and such dyskinesias, jerky movements, uncontrolled, very different from the hesitant, slow, shuffling movements in an unmedicated Parkinson's patient, which you saw in a previous video. These dyskinesias are very common in public appearances of medicated Parkinson's disease patients. The mechanism by which L-DOPA causes dyskinesias is basically unknown. We all assume that it's an outside-in mechanism in which continued activation of GI-coupled pathways ultimately leads to changes in protein synthesis, which are only slowly reversed when the medication is discontinued. But that's really just a hypothesis, that it's an outside-in mechanism. In addition, the side effects include visual hallucinations, other psychotic symptoms, sleep disturbances, and confusion in patients who take L-DOPA. There's also a so-called on-off phenomenon, abrupt, transient fluctuations in the severity of Parkinsonism. So note here we're using Parkinsonism in terms of the movement disorder to distinguish it as a cluster of symptoms rather than as the disease. So these fluctuations occur at intervals throughout the day. not related to the acute dosing of L-DOPA. And so what exactly causes the on-off phenomenon remains a mystery among the side effects of L-DOPA. Our recommended textbook by Nestler and colleagues does a very good job of describing drugs that are occasionally used for relieving Parkinson's disease symptoms among patients. The monoamine oxidase, or MAO, type B inhibitors are useful because they prevent dopamine from being destroyed after it's been released into the extracellular medium, and therefore they prolong the action of dopamine in those dopaminergic neurons that still remain. Apparently, MAO-B inhibitors have been used successfully for managing Parkinson's disease in some patients. Physicians also use muscarinic antagonists. You remember the muscarinic acetylcholine receptor, a G protein coupled receptor. It may help the action of certain key interneurons, GABAergic neurons, in the striatum. And it's not abundantly clear how this affects the symptoms of Parkinson's disease directly. Some people use amantadine for Parkinson's disease. Amantadine blocks NMDA receptors, which, as you'll remember, are glutamate receptors. They are calcium-permeant glutamate receptors. And so the thinking here is that amantadine may decrease excitotoxicity via activation of NMDA receptors. Antioxidants, such as coenzyme Q10, perhaps creatine, are thought to act because of the toxins that have been identified that seem to poison particularly mitochondria in dopaminergic neurons. So the thinking is that if you can prevent the formation of reactive oxygen species, either by helping the mitochondria or by preventing the oxidation of dopamine, then you have provided a way for dopamine neurons to function better. And finally, adenosine receptor antagonists, which are GS coupled, either the A1 adenosine receptor or the adenosine 2A receptor, have been used for Parkinson's. The mechanism of these antagonists and of their helpful effects is uncertain, at least to me. Now, another therapy for Parkinson's disease is not a drug, but it is so effective that we should mention it here. It is deep brain stimulation. Here is our diagram of the basal ganglia and the midbrain. For a period of a couple of decades, neurosurgeons interrupted the feedback loops which cause tremor by literally ablating, sometimes cauterizing, individual groups of neurons